Court and I got together to form the Psychedelics and Pain Association after a lot of conversations and research, and realizing that there are researchers out there already working on this topic. And it would be lovely to get them together, coordinate patient communities so people can understand the science for themselves and make their own educated decisions as adults in America. And then have not just researchers, but clinicians, actual physicians working on this topic, understanding the new science of pain. So that's why I'm here. I'm really excited for you to all meet our guests, and I'll let you guys take it away.
Okay. Um, Hi there. I'm Court Wing, co-founder, as Joe said, of the Psychedelics and Pain Association, as well as Remap Therapeutics, and very, very excited to be presenting tonight with Dr. Burton Tabaac, who I've spoken to so many times over the phone and via email, but I'm not sure if we've met in person before, but certainly this is our first video interaction. And just a huge, huge thanks out there to John and Kate of the Nevada Coalition for Psychedelic Medicine for hosting us tonight and for giving us the opportunity to share these emerging trends in clinical evidence and where we see things going. So, um, Burton, do you have anything to say before I start?
Yeah, I'll just introduce myself. Thank you, Court, for showing up and for the invitation. Thank you to Joe Moore for all of your efforts in getting education out there. And my background is as a associate professor of neurology, as well as a practicing clinical neurologist. And psychedelics is an area of research that I'm actively engaged in as it pertains to my involvement with the Johns Hopkins lab under Gul Dolan and Steven Zeidler. And so the perspective that I bring is that of the neurological lens. And so with that, Court, let's get started.
Okay, sir. Everybody, just advance notice. I do get kind of emotional about this topic, as this touches people's lives in a way that is very profound and lasting, as it did for me. Also, I've got a lot of material to cover, so I'm going to be hustling. So please excuse the pace. Anyways, let me just pull up sharing here and give me 1 second. And let's see if I go this way. Can everyone see that? Thumbs up, I think. Yeah. Okay. Thank you so much. Okay. So this is psychedelics and chronic pain, emerging clinical perspectives. I'm Court Wing. I'll be discussing my issues of major depressive disorder and persistent chronic pain, as well as a few case studies and key mechanisms action for psychedelic medicine. So, excuse me, those are my affiliations and disclosures. So I have a 30 plus year background maximizing client athletic performance, injury, and recovery. Pretty extensive career in pain and performance and a wide variety of interdisciplinary practices. Oop, not that one. This one. Nope, nope. It just wants me to swipe. Okay. But crucial to this discussion, I was a study participant in the NYU USONA 2020 clinical trial of psilocybin for major depressive disorder. An increasingly treatment-resistant episode of depression for over 5 years. And by the end of day, I was in full remission from that high-level depression. It was a low, moderate, severe depression, low 40s in the MADRS score. But more fascinatingly, by the next day, I had complete elimination of low to moderate chronic pain. And that's what drove me into investigating everything that happened. And that's how the Psychedelics of Pain Association was born, along with Remap Therapeutics. Um, This is the actual dosing room at NYU, and there is my primary investigator, Dr. Stephen Ross. There on the right, that's the actual couch where this happened. That's the actual cup where I received my capsule, 25 milligrams of synthetic psilocybin. But just the most astonishing thing, other than the complete remission from my depression, was just the utter relief from low to moderate chronic pain that had been ongoing. And a couple weeks before my dosing, I had read this report showing that this wasn't just a psychological reframing, but that there was actual structural neuroplasticity. And due to my background in treating people with chronic pain, I was very familiar with neuroplasticity being a key driver to improving people's chronic pain conditions via visual, vestibular, and proprioceptive inputs, and that there were many changes in structural neuroplasticity for people. And so, you know, how did we know that I was actually in remission? Well, if you look at the study data here, if you look at this graph here on the right with the descending lines, if you go from the middle over to the left by about 5, that one is me, right? Went from, again, low 40s MADRS score, which is a depression inventory, down to 0 within a day. And this was also verified, in fact, by the study trial sponsors use Sona, and we could see that my baseline by day 8 was down to 0, but that was misleading because they were asking in the last week, have you? And so we had to wait till the end of the week before we could say, yes, I'm in full remission, right? So, but the thing is, this with this low moderate chronic pain being gone, the next morning I woke up and suddenly I could do one-legged pistol squats again. There was no pain anywhere in my body. I had felt as if I'd almost had a low case of fibromyalgia. I would bang into something and there would be achiness that would just linger for the rest of the day. I used to be one of the most mobile people at my gym. I had been like this person that was known for getting other people out of pain. And here I was now struggling with my own chronic pain that just would never seem to resolve. Um, and so in that state, I suddenly recalled a young vet that had worked with me more than a decade earlier who had returned from Iraq and had developed a case of complex regional pain syndrome. And it was non-responsive. And he looked like the finished product of joining a gym. But in fact, he was like in just unending chronic pain 24/7. His leg felt it was like on fire nonstop. And eventually, in a desperate attempt for relief, he'd had his leg surgically amputated. And so I was lying there, and the day after, and I just suddenly asked myself, with remission being driven this strongly and robustly by this high dose psilocybin, and with visual field interaction that's happening this richly, as psychedelics are known for their visual field interaction, why couldn't you combine high dose psilocybin with mirror box therapy to treat phantom limb pain just all at once? And mirror box therapy is when you use a mirror to reflect back the image of the remaining limb, right? And in the nervous system, there's a hierarchy of visual, vestibular, proprioceptive, right? So, and your visual field dominates. And it's so impactful that seeing the image of the reflected limb is enough to stop the pain. So when people lose a limb, it creates this alarm in the nervous system that something is missing. There's this huge loss of signal. So in a evolutionary context, that's very threatening. You're about to bleed out, right? And I was also familiar from my original certification through an organization called Z Health. I should be clear, I'm not a doctor, I'm not a therapist. I just have a number of very advanced certifications I was lucky to be able to take part in. And I was aware that Dr. Schindler at Yale had been working with cluster headache communities, which is one of the most painful conditions known to medicine, and they had discovered that psilocybin and other classic serotonergic psychedelics were very impactful on their pain states. But I was fixated on phantom limb pain, right? And this was something that was just in my background from years before. Um, I was fixated on phantom limb pain, and I rapidly discovered that there was a study published in Japan in 1962 on LSD and phantom limb pain, and they were using 50 micrograms of LSD to keep people cognitively available. And 8 people had gone through it, and 7 of them had either had full remission or significant relief by end of day from their phantom limb pain. And so, everyone else was citing the CAST study. The CAST study was another LSD trial using 100 micrograms, where they were looking at people with terminal cancer, dry gangrene, and advanced shingles, right? And these are all end stage pain people, horrible types of pain. They compared it against 2 of the major opioids of the day, Dilaudid and Demerol, which provide about 3 hours of relief each, but psychedelics provided something like 19 plus hours. And it was just incredible how long that it lasted for them. And is one of the first studies out there. But I was fixated on phantom limb pain. I was trying to figure out how will I convey this. And as I was exiting the trial, Dr. Joel Castellanos and the entire team at UCSD published their landmark review, Chronic Pain and Psychedelics, a review and proposed mechanism of action. And buried within was the case study of Albert Lin, treating his intractable phantom limb pain with high-dose psilocybin and mirror box therapy, exactly as I had seen, right? Here we can see them working in a graduate lounge. He's on high-dose psilocybin right now, and they're using different types of, that's a fake foot, and they're using different types of neurovisual modulation here. And that's V.S. Ramachandran, the renowned neuroscientist, pointing fairly intensely there, who had discovered mirror box therapy, right? And when they combine, here we can see comparatively, when you combine psychedelics with an adjunctive therapy, and this is crucial, when you combine psychedelics with an adjunctive therapy, it's more impactful and enduring. It is an impact booster for neuroplasticity, right? When you use psychedelics on their own, Albert Lin had used them on his own. He got about 12 hours of complete analgesic relief from his very severe phantom limb pain, but then it faded, right? And he had been doing mirror box therapy right there at UCSD with V.S. Ramachandran, and it works only as long as you're doing it, while you're doing it acutely. And it takes a lot of practice to drive neuroplastic adaptations in the body. It actually takes a fairly high volume and intensity and novelty to make it sticky to the nervous system. But when you combine them, you can see over here, he had 24 hours of relief, then a 50% reduction in his total pain baseline. And then when he was doing all this work in the lab, he finally, at 5 weeks, goes into total remission. So when we're talking about key mechanisms of action, right? When we're talking about key mechanisms of action, what's at play here? So first off is the 5-HT2A serotonin receptor, right? It's one of the only ones known for creating persisting descending inhibition past nerve ligation, right? Past nerve damage. So that's why we're seeing, a lot of emerging reports, and you'll hear some more in a little bit, of people being able to treat peripheral neuropathy, neuropathic pain, or nerve denervation, right? Improving with the use of psychedelics. And there's a lot of emerging evidence. In fact, there's some new evidence just released in Nature about psychedelics improving neuropathic pain and improving the performance of nerve pain medicine, gabapentinoids, right? So it seems to, with duration, perform better with repeated treatment. Another key mechanism of action, right? So this tends to come from what we're seeing coming out of Robin Carhart Harris's work, is around cortical reorganization, right? So the brain can develop these very entrenched maladaptive adaptations, whether that's in depression, PTSD, or chronic pain, right? Where a hypersensitized response becomes fixated and entrenched, and it's very hard to change that. So there's top-down versus bottom-up predictive processing. And usually bottom-up sensory processing should be correcting prediction errors that come top down from the brain about how you're supposed to experience reality, including your own body, right? And so when you're reweighting these things, you're going from a cognitively inflexible standpoint to one that's more responsive to what's actually happening in reality and within your own body, right? Your sensory. And another thing that we know about psychedelics and chronic pain is there's this bidirectionality of pain. So like there's this thing known as the psychological and physical vicious circles. And as you go through having an impoverished mood, that also starts to cause a lack of activity and a deconditioning of the nervous system. And they each reinforce one another in this negative cycle, this negative reinforcement cycle that makes both the pain and the impoverished mood worse and worse and worse, right? And we know that's true because there was a retrospective analysis published by Dr. Devin Christie involving looking at one of the MDMA safety trials. And the people in that trial had very high levels, as most people with PTSD do, and often people with depression, high levels of chronic pain, right? And a non-stated outcome that they discovered when they analyzed some of the measures was that the people with some of the worst PTSD had some of the best improvements in their chronic pain. Yet they were never told that was going to be an outcome. So there was no pre-bias expecting that. So another incredible thing about psychedelics and chronic pain is the fact that they're profoundly, potently anti-inflammatory, right? So in some cases, depending on the psychedelic, 700 times more powerful than corticosteroids below the level of psychoactivity. So that's a very, very low dose of a psychedelic. So it's not causing, psychoactivity, but it's still providing this profound anti-inflammatory baseline. And yet, fascinatingly, they are not immunosuppressive. They just return your inflammatory response back to its normal baseline, not suppressing it down below to the point where it starts to become, an infection risk and things like that. And we see these acute reduction of biomarkers that signal inflammation like TNF alpha, IL-6, C-reactive protein, and also seems to create increased resilience to stress response, right? Again, as I mentioned at the very beginning, we see this big, big change in structural neuroplasticity. I saw that study and I was already familiar with all the ways that the brain can change. And what we're finding out is that a single dose of psilocybin can lead to a 10% increase in spinal density and spine head width, right? So the tree trunk of your nerve gets thicker, the branches get bushier, they're getting greener and more leafy, and there's more synaptogenesis, more connections across multiple populations of previously what were significantly atrophied areas in the brain for pain processing or things like depression, right? Another crucial factor here is that we're seeing this meta-neuroplastic window and critical period reopening, right? So that psychedelics are impact boosters for adjunctive therapy. As previously stated, when Albert Lin was combining his high-dose psilocybin with mirror box therapy, together they lasted longer. Why is this, right? So the speculation is that, and there's good developing evidence around this, again, from Dr. Gould-Delaine and the team that she's been working with all this time. But when we look at different psychedelics, ketamine only lasts 40 hours. The critical period reopening for it because it's a very short acting psychedelic. Psilocybin is longer acting, 4 to 6 hours. So we see this critical period reopening of about 2 weeks. MDMA also about 2 weeks has it's in a similar time frame of its acute activity. LSD lasts 12 hours. So that's closer to 3 weeks. And what is a critical period reopening? Just to be clear, it's this period of metaplasticity, of deep malleability to the nervous system where you're almost getting baseline level programming. We often see this with toddlers acquiring speech, or teenagers acquiring social norms, or little geese learning who's their mother and who to follow, right? That is a critical period reopening. So the idea here is that psychedelics are letting you reopen this period of malleability where you can regain lost function, right? Regain lost function, which is, if you've had something happen to you like a stroke or a traumatic brain injury, spinal cord injury, you can reacquire these motor components, right? So what I'd like to do now is just cover real quickly, and thank you for bearing with me, three case reports showing what this looks like in the wild. So these are three different clients that I've worked with, or done a case study on, who either had a condition of central sensitization, where the central nervous system becomes very, very active in promoting an heightened alarmed response to any input and interpreting it as pain, right? So something like fibromyalgia, something like complex regional pain syndrome, something like phantom limb pain, right? Or they have severe neuropathic pain, really significant damage or dysfunction to the nervous tissue itself, also creating severe pain. You can think of something like peripheral neuropathy from diabetes, or after chemotherapy as being neuropathic pain. So one person here will be someone with complex regional pain syndrome. The next person will have neuropathic pain that also they're both having to happen in the lateral thigh and the nerve that's there. And then the last one will be someone with a phantom limb pain combined with CRPS. And they all had pain baselines of 7 to 9 out of 10, having exhausted standard of care. I should mention very, very quickly, normally Marianne is in these discussions. Um, uh, she was our first published case study on using psilocybin and MDMA to treat long COVID. I'm going to kind of dance past her, but I'm keeping her here to your notice because her case study was just awarded by the publisher as being one of the most top viewed articles published that year in clinical case reports. One of the most top viewed. That's really saying something for the interest and need for this type of work. So 44-year-old Canadian mother, she was infected with COVID. She had very severe long COVID, significant post-exertional collapse and malaise from exercise, profound cognitive decline, very intense headaches from the COVID. And what she did was first, she tried a little bit of psilocybin and got about something like 30% relief. About a month later, she just tried combining a higher dose of MDMA and psilocybin, and she experienced 80% relief from all of her symptoms. And not noted in the case study that was published is the fact that she had profound recovery of her energy production. So she was able to start exercising again almost immediately, and exercising more and more on subsequent days. So that implies improvements in energy production. So most likely mitochondrial function, perhaps some autonomic regulation of energy perception or production as well. Our next case study here, and again, I apologize for the pace, is Lynn Watkins. She also, her case study won the same award that Marianne's case study just won, among a top viewed article from the publisher Wiley, among the most viewed articles published that year. So again, very, very high interest in this work. She's a 56-year-old JAG officer judge, 25 years of service. She had a botched surgery where they cinched down the lap belt too hard, and it killed the nerve in her lateral thigh. And that started morphing into complex regional pain syndrome, one of the worst pains known. And she also developed burning mouth syndrome. She had severe foot neuromas as a result of all this, started developing PTSD, depression, anxiety. Eventually, she had to medically retire. This is a central generated syndrome, and so that means it's complex regional. By regional, I mean whole swaths of the body. So this is what can happen where you see trophic changes in the tissue because of what's happening up in the central nervous system around that portion of the body. The mapping for that portion of the body is now dysfunctional, right? So there was an earlier case series, again, from Dr. Castellanos' team at UCSD, where they had the very first published this case series where they covered people using macrodoses and microdoses, and one of those people was with CRPS. In our case, Lynn worked with us, and she had 3 doses over the course of a week, combined with neurovisual modulation, tactile word processing programming, nerve glides, all sorts of different types of visual and vestibular inputs. And uh, within 90 minutes, her pain dropped down to 0. Fascinatingly, also, her toes, which had not moved in more than 9 years post-op, to remove knuckles from her toes to help stop the pain from the neuromas, right? Um, they began moving for the very first time in 9 years, despite routine physiotherapy. So her pain from the neuromas and the CRPS went to 0 within 60 to 90 minutes. Her toes started moving for the first time in 9 years, within 60 to 90 minutes, right? And the last that she was using ketamine infusions pretty intensely, normally would bring her down to a 0, but the last time she did it, it only brought her down to a 4. Within a month afterwards, on the BPI brief pain inventory, her pain was at 0. Her 9-month follow-up, it was at 0. At 15 months, it was at 0. She recently worked with us again after she had a slight relapse, and now her pain is at 0 again as well. Um, the next person, I'm just checking time. I'm going to tie this up within the next about 3.5 minutes here and turn this over to Burton. Was a client who had neuropathic pain in her lateral femoral nerve and lumbopelvic region, coupled with complex PTSD. It began after she had a hip surgery to treat pain from a fall, right? The surgeon claimed to have cleaned up the hip joint capsule, but unfortunately, we believe that reduced some of her mechanoceptors, which probably helped drive the pain up, and maybe also had some damage to some of the much smaller femoral nerve branches involving that lumbopelvic region. She was told at a certain point that her pain was psychosomatic after negative imaging. They didn't see anything on the imaging, so they're like, it must be psychosomatic, even in spite of the fact that that pain could be reproduced with movement, implying it was in fact neuropathic, neurogenic, right? She had been prescribed very strong opioids for multiple years, but those became effective in the summer of 24 after she had a ligamental tear in her knee, and there also a close family trauma, and her pain baseline immediately increased to 7 to 9 out of 10, largely becoming non-responsive to opioids, just suffering intensely. We also suspect there was opioid-induced hyperalgesia, and so she began this program of motor control, nerve glides, tactile reprocessing programming, and started trying microdosing as well about 7 weeks ahead of our retreat programming. Relief during this period was kind of non-linear, with intermediate periods of 0 pain up to 6 days, which was some of the most sustained pain relief she'd experienced up to that point. She had a total loss of fear of motion, kinesiophobia, and she had a restoration of this range of motion. She's a former high-level performing athlete, and that had been reduced significantly. But then she would also get pain flares, which were contributed to by multiple social stressors. She also had 3 dosing sessions during the retreat, followed immediately by neuromodulatory interventions, reducing her pain baseline down to 0. Her largest dose was also a combo of MDMA plus psilocybin, bringing her PTS score essentially down to 0 and causing a complete remission of her collateral residual eating disorder, restoring all her satiety and hedonic controls. So food became satisfying, taste became exciting again. She gained about 10 pounds in 8 weeks. And later, due to a dosing error, and we suspect some hormonal changes post-programming that caused about a 3-month relapse after 8 weeks of remission. But we had our neuropharmacologist, Jag Kaur Dial from Therasil, do a consult with her. and found that she needed to go on menopause replacement therapy. And so that helped to drive receptor resensitization. Microdosing became it started working again. She also had some help with the opioid use that had grown in place while she was treating her pain originally. And she became responsive again to physiotherapy, exercise, and neuromodulation. And that restored her remission for the last 7 months. She's returned to an active, engaged outdoor movement and family lifestyle. The last one I'll talk about is a client that came to us after reading about our work with Lynn, who had developed CRPS in her right foot after injuring it about 4.5 years ago. Multiple foot interventions led to increasing pain, which eventually led to very intense CRPS, leading to, after multiple failed interventions there, finally deciding to get her leg amputated. And then that led to not being able to use her leg and having to be in a wheelchair for nearly 18 months because she could not wear a socket for her artificial limb. Eventually, she decided to get what's called an osseointegration, where the artificial limb goes straight into the bone. But that just launched into just a horrible pain baseline, this massive CRPS and phantom limb pain flare of 8 out of 10. So she also began a program of motor control, nerve glides, tactile reprocessing programming, neurovisual modulation and microdosing, psilocybin and or LSD 8 weeks before her retreat programming. Some of her relief was also nonlinear, where with the neuromodulation, we could get her pain down by 30 to 60% during this preparation stage. The one thing that consistently gave her the most release was doing about 50 micrograms, just like the Kurumaro study of LSD, where her pain relief would be up to 2 days, like 8 hours to 2 days with almost no psychoactivity. That's very consistent we see in many pain patients. Um, we at the retreat we had her do more neuromodulatory interventions combined with higher doses, bringing her pain baseline down to zero. The largest dose was 300 mics of LSD. She didn't ever have a mystical or psychedelic experience. Psilocybin also kind of underperformed that way, but she did have profound relief. But afterwards, after these larger doses, her responsive to microdoses decreased. And then we did another analysis of her hormone levels, and estrogen has a profound effect on the number of 5-HT2A receptors available. So after she began menopause replacement therapy, her responsiveness was restored. So, she has been in significant relief now for the last 4 months. Her pain baseline has dropped way, way down from the 8 to 10 that it was trending towards. Now it's down to 4 or 5. The lowest it goes is 2 to 3. The highest 7, 8, but really the highest it ever really gets anymore is 6. And it's continuing to trend downwards. And now she walks. She has a very active family and social lifestyle. And she's making plans and following up on them. And her daily step count is exceeding 9K. That's where I'm going to conclude it today. Just to say these people aren't alone. There are multiple studies. We all need to get very, very familiar with the mechanism of action of psychedelics on pain neurology and all the different ways it can be used. Just thank you all.
Excellent. Wow. Court, that was a beautiful overview. A lot of information there to digest. Reminds me of med school when just information was being coming at
Fire
me
hose.
like a fire hose. Yeah. So with that, I'm gonna look at the time that we have remaining and shift my approach a bit. And what I'm going to do is I'm going to offer a bit of an overview, kind of a 20,000 foot view of how I see the space with a little bit of refinement on how the underlying mechanism can be understood for the general population. And then with the remaining time, I would love to invite a little bit of banter. So if there are any questions from the audience, I want to invite you to start thinking about what those questions might be. We can enter them into the chat and then we can field them. So with that, here's my take. While the conversation around psychedelics has really been dominated by their potential in mood, namely depression, anxiety, and addiction, we recognize that there's this growing body of recent research highlighting this major area where we could deliver transformative results, specifically chronic pain relief. Now, there is recent preclinical work that stands out in my mind. In October of 2025, Penn Medicine researchers showed that a single dose of psilocybin in mouse models of chronic nerve injury and inflammatory pain not only reduced pain sensitivity, but also eased the anxiety and depression-like behaviors that make the pain feel worse. And this speaks to what Court spoke about, how the psychological underpinning can really magnify and augment symptoms. Now, in that study, the benefits lasted nearly 2 weeks from a single dose. This points to the effects on shared brain circuits linking pain and mood. Also, earlier this month alone, the University of Reading scientists reported that one dose of psilocybin cut nerve pain in mice for up to a full month and actually boosted the effectiveness of standard painkillers like gabapentin, which was also mentioned. So there is this parallel effect where there's synergy between prescription medications and psychedelics. And it's posited that this has to do with the fact that psychedelics can reduce the tolerance on certain therapeutics. The human evidence is, of course, building too. Now, there are small pilots and case series and ongoing trials in academic centers looking at psychedelics for treating fibromyalgia, neuropathic pain, and chronic low back pain, as we see in the UCSF study, currently enrolling participants, and other conditions showing reductions in pain severity and interference, lower opioid needs, better sleep, and improved quality of life, often after just 1 or 2 sessions. So with that, there's this recognition that chronic pain is affecting over 50 million Americans and more than 1 billion individuals worldwide. This drives massive healthcare spending, disability, and a vicious cycle with depression that daily medications often fail to break. And so I am hopeful and optimistic that psychedelics will offer a tool. And again, I think it's really important that we understand there's 2 different mechanisms at play. So I want to take a moment and really underscore them, because this is a potential takeaway from this talk tonight. First is that there is the biochemical, physiological effects that are happening with multiple different mechanisms. There's the anti-inflammatory property, and then there's also the ability to break loops, similar to what we see in the mental health space, where if there's rumination as it pertains to depression, the same phenomenology can be seen with pain, where there's cycles, cyclical patterns, and psychedelics can interject and break those loops. And then indirectly, this second pathway where we recognize that psychologically undertreated depression and or anxiety can really magnify and exacerbate pain. We can invoke lots of different examples. I think that when it comes to cluster headaches and migraines, psilocybin has been studied. And I am most intrigued by the work being conducted looking at iboga and ibogaine, of course, a root bark from Gabon, Africa, that is a little bit novel in its mechanism. And what we have learned through study is that this can rewire the opioid circuits in the brain. And so this speaks to the pain responsiveness and can also break the loops of tolerance that we can see, which will lend patients to being able to respond and have better effects from lower doses of therapeutics. Now, the last theme that I want to share and introduce before we turn it over to questions. So this is a great time to start entering any questions that you might have in the chat, is this. It took over 50 years from the time anesthetics were discovered and the different molecules that are currently used in anesthesia, to be introduced into medicine. There was this multiple decade long period where there was skepticism and uncertainty. And I think that really parallels what we're actually seeing today with our current era of cultural judgment and uncertainty as it pertains to psychedelics. And just think about how profound and impactful modern anesthesia has been in healthcare and pairing with surgical intervention. And so I'll be really curious to see how the attitudes and the way in which psychedelics are introduced, and specifically as it applies to treating things beyond the mental health scope, specifically as we're speaking tonight on pain constellation. Now, with that, let's turn it over to the people in the audience to field some questions as they come up. I'll be able to give my take, and then we'll also invite Court back in to share his thoughts. Looks like the first question that came in, and I think Court, you're on mute, relates to communication, more information. So I would, for my piece, going to encourage people to check out both the Sierra Psychedelic Society website, which is an educational platform that offers information, and also the merits and the value of integration, because we recognize that psychedelics are context dependent, and the work only begins with a dose and can really be maximized when paired with integration. And the second organization is going to be NCPM, or Nevada Coalition for Psychedelic Medicines. Court.
I believe we've got if we're going for questions, do you want me to read out loud the first one from the Q&A?
Sure.
So I'm seeing someone has written,
I
am seeing several clients who have tried 5-HT2A acting substances many times and they were not able to resolve their chronic pain until we combine the neuroplastogen, ketamine with skilled bodywork myofascial. So my hypothesis is that the critical window with the learning, intervention, or priming is required for change. I've had long-lasting pain relief results with just a few treatments a couple weeks apart. That sounds like Suze Vero maybe, or Burroughs. So hello, if that's you. Any takes on that?
I think that ketamine as a molecule is quite interesting. It being not a classic psychedelic, but more of an anesthetic with dissociative properties.
Right.
It acts differently and uniquely to break patterns and break loops. I also heard invoking of other modalities. And this is where I, as a holistic practitioner in both allopathic medicine, but also the respect and the awareness that there is a mysticism to psychedelics, and a recognition that we don't have all of the answers, that there are multiple modalities out there. And so whether we're invoking breath work or somatic practices, alternative methods like acupuncture and cupping, every individual is different. This is where the art of medicine comes in, and there's not a one size fits all. And so I feel that each individual should do what works for them, and finding the best potential cocktail of modalities that achieves efficacy while also ensuring safety is always a path worthwhile.
I know a lot of the work that you guys are working on the Fathom project involves combined modalities very intensively. Also with I believe when I had Steven Seiler on with us at our Psychedelic and Pain Symposium this past summer, he highlighted how a lot of the research was showing that focusing on movement quality, not just completion of text, but movement quality with the stated goal of improving, that drove again enough intensity in that neuroplasticity so that we would see those improvements. So I think that's also validated in the pain study case series in Pain Journal from UCSD, where they showed that someone combining their psilocybin with their home physiotherapy routine produced pain relief for more than 2 weeks at a time versus either one in isolation. So that's great. What do we have here next? Is that, I think that one was answered. Okay. And how about from the chat? We have the Q&A function, guys, but what do we have down here? In terms of biosynthetic molecules, is there expected to be differences in results versus organic consumption of natural chemicals and their entourage chemicals, specifically psilocybin, baeocystin? Nice question.
Love this question. This
Yeah.
is really cool debate because we're seeing companies coming out with synthetic formulations of naturally occurring compounds. And the reason for that is because if you think about it from a Western medicine model, in order to get these FDA approved, we have to be able to confirm dose. And so if you're to take a biomass of mushrooms, you're going to have a lot of variability. Even if the bulk mass is the same, the active psilocybin or psilocin content may vary. And so what synthetic psychedelics offer is a model for objective science. Now, that said, there is a field that looks at the entourage effect, which posits that the medicinal benefits of plant medicine are not uh, attributed from the psilocybin alone. Or if we think about Wachuma or San Pedro, which has mescaline as its active psychedelic compound, that it's not just the mescaline that's offering potentially therapeutic benefit, but that there are other alkaloids and other molecules that are part of a naturally occurring plant that may offer synergistic benefit that pair with the psilocybin or the mescaline that ultimately promote anti-inflammatory properties, metaplasticity, what have you. And so, in terms of how we think about this, there is something to be said about the entourage effect. And when we have to think about this, we have to put our frame of reference and understand the cultural context while also understanding the models that allow the masses to obtain these medicines through the current systems we have in place in the Western world.
Well, and interesting to note that we don't even know which receptor necessarily a benefit is coming from. Like the recent stuff that's come out involving low dose psilocybin being able to treat essentially diet-induced type 2 diabetes in mice and reversing that without any dietary changes over the course of 4 weeks. Huge, everything that we're seeing with all these, semi-glutide type drugs. But at the same time, it's not happening on 5-HT2A, it's 5-HT2B. And then, who knows what the secondary messenger pathways are doing. So I think most of what's been forgotten within the indigenous context is, we'll be discovering it, rediscovering it for the next probably 100 years, if not longer. But it's an exciting time. We have, let's see, what's our next question here? Does one have to get off of their, oh God. Okay. Here we go. Does one have to get off of their medication like gabapentin and amitriptyline if they are trying psilocybin? Ah,
Yeah, so this is a question that asks about potential medication interaction
correct.
when weaving traditional plant medicines with prescription medications. And there are absolutely potential interactions that can occur, especially for prescription medications that interact with the serotonin system. And it also depends on which psychedelic we are speaking about. So, there's a lot of nuance here, and I'm not offering any medical advice in this format, but this is an opportunity where you want to find a doctor or a clinician who is well versed in this space. Unfortunately, psychedelics are not part of a 4-year conventional medical education career, so it's really incumbent upon the clinician to do their own research. Now, when I was in my practice, I identified this as a gap where a lot of my colleagues were coming to me with questions. And so last year, several colleagues and I put together um, a primer series for primary care clinicians that takes everything that has been published in the literature, the medical literature to date, hundreds of papers, and synthesizes it down to 5 or 6 pages for each psychedelic, where you can have a doctor who's seeing a patient who's interested in going on an ayahuasca retreat, for example, who might have not even had heard of what ayahuasca is, look at this primer and understand the nuance. Now, that said, to give you some generalizations, what we understand with the way in which SSRIs interact with psilocybin. So we're talking about medications, antidepressants like Paxil or Prozac, Zoloft. Psilocybin actually can be blunted, meaning that there's less of a potency when taken with SSRIs rather than contraindication. That cannot be said with something like ayahuasca, which is a medicine, it's DMT in a brew, where because it's combined with a monoamine oxidase inhibitor, there can actually
Correct.
be real risk of harm if someone is taking a medication like amitriptyline, a tricyclic antidepressant. Um, if we think about a boga has its own unique safety concerns when paired with other prescription medications because there are potential cardiac complications because it can prolong the QT or the
In the
rhythm.
interval. Yeah.
And so, with that, this is where it's really important that Western medicine trained doctors are getting up to pace, getting up to speed, because these medicines, these psychedelic therapeutics, are evolving as a more accepted option in in the States and in the Western world. And the American Psychiatric Society national meeting was just held in California last week, where there were talks on psychedelics. And so we are seeing movement. So, to answer your question, I think that it really depends on what psychedelic we're speaking about, and then specifically what prescription medications are being spoken about, and also what dose we're speaking about. Are we talking about a microdosing protocol, a macrodosing context? And so the fact that you're asking these questions and you're not just diving in head first is a good sign, but absolutely would encourage you to continue this research and make sure that you're getting the appropriate, well-versed medical advice from someone who has studied these medicines.
I could recommend CJ Spotswood, who's our principal psychiatric nurse practitioner, who wrote the book, the Microdosing Guidebook, second half of which is devoted towards handing to your clinician saying your patient has just come in asking, can they microdose with their medication? Here's the data. He's great for consulting. Again, Jag Kaur Deal, who's a neuropharmacologist who works for Therasil. She also does consulting and has been invaluable to us. Both of those are people I would absolutely hand over and were invaluable in some of the case studies I was mentioning before. So, who do we have? What do we have down here? Should I jump back over to the now? There's more in the Q&A. Okay. Um, Let's see. Dr. Castellanos is treating me for PTSD, TBI, anxiety, depression, migraines. I had SGB. I don't know what that is. And I am using ketamine, psilocybin, LSD. How do I find proper dose amounts? Oh boy. So right back to, and sorry to hear you're going through all that, Susan. I think that just actually got answered to a degree. We can look towards certainly previous studies that are out there. As I mentioned, the Kurumaro study, they were using fairly low dose LSD to treat their phantom limb pain, but it sounds like you have a number of things, and it would be very difficult to give a specific answer here, particularly since most people that are in extreme chronic pain or neurodegeneration or some type of autoimmune condition, they're almost always polypharma. It's not just one drug that you're on. Usually it's a cocktail of them. So having somebody who's qualified to do a medication schedule review and analysis, and then looking for these drug-drug interactions with harm reduction in mind, as Dr. Tabaac just shared with us. I can't urge that enough. So yeah. What else do we have here? Maybe go back to the where are we at? We're closing in. I am sorry. I It's so fast. Let's see. Also, would you recommend trying less strong? Let's see. You actually already asked a question, so I'm going to, I think you did skip. Yes, you did. So we're going to go to somebody else. Um, I propose those other molecules are understudied and we can't really say much at this point. Oh, this is Joe. Okay. We should study them. All right. I agree. Dr. Tabak, could you speak a bit more about the Fathom program? Yes. Apologies if I misheard the name. I'd love to hear more about what this looks like in real time from patient management perspective. Oh, yeah. Why don't we go for it?
Yeah, sure. So the Fathom study is specifically looking at the potential for psychedelic healing with adjunct therapy. And the study that's currently recruiting patients are those that have suffered a stroke. Taking a step back, I want to acknowledge that the hypothesis behind this study is looking at the potential for, again, psychedelics to reopen critical periods, windows of malleability to promote healing. So this can translate to lots of different neurological indications, uh, inclusive of traumatic brain injury, multiple sclerosis, brain infections, and stroke. Now, stroke being one of the more higher incidence diagnoses, with many millions of individuals affected. The intention of this study is to take patients who are at least a year out from their stroke when the normal window for recovery has closed. So it doesn't matter how much physical therapy one does, after a certain period of time, there's a plateau, and then patients are left with some degree of debility, weakness, for example, of one limb. And this study is assessing if patients are given a large dose of psilocybin, not a microdose, we're talking about a consciousness altering dose, and paired with the right context, in this example, a motor context and physical therapy, if we can promote healing. Now, this potentially could be a paradigm shift in the way in which stroke patients are rehabilitated, because to date there has been nothing that has, with lots of different compounds that have been studied, nothing that really offers recovery after a certain period. So the Fathom study in its current model is a phase 1 safety study, looking at the safety of pairing psilocybin with chronic stroke patients, and then of course, there'll be a phase 2 efficacy study that follows that. And more information can be found clinicaltrials.gov. The phase 1 is currently only enrolling participants in Baltimore. The phase 2 will be a multi-site nationwide. And then one could extrapolate the findings from that into other potential diagnoses of neurological brain injury.
Just wanted to highlight that question was from Dr. Amy McKinnon, who is running a couple of incredible rehab clinics up in Calgary. Great practitioner, and always a thrill to talk with her. Anyways, so we're a little bit past. Should we do one more from Q&A and then tie it up? Okay, let's see what we've
Yes.
got here. Again, apologies for having run a little long. Let's see. Where are we going to go here? A couple. And Susan said it was a stellar ganglion block. Thank you. Can you touch on the future of accessibility in the natural medicine facilitation space? Oh boy.
This is a great
Yeah.
question that I feel that NCPM, Nevada Coalition for Psychedelic Medicines, can really guide this landscape. So this is really a medical legal question. And the individuals that lead that organization, namely John Dalton, former SEAL, and Kate Cotter, a good friend, are on top of the legislative map of the country. There are multiple different states that have a path of decriminalization that include Colorado, New Mexico, and um, Oregon. And there are many jurisdictions and local cities that have different bills that have passed that offer a path to potential legalization. There's an executive order at the federal level that was just put out, which has directly led to a clinical trial through the VA treating patients with PTSD via MDMA. And so this is a rapidly evolving landscape, and I think it changes on a weekly and monthly basis, just the different efforts that are being passed on a legislative effort. One thing that you can do is there are often hearings at the state and local level. And so if you want to get involved, pairing with organizations like NCPM to offer testimony and get your voice heard is one of the best ways at a grassroots level to affect change.
It also seems that between waiting for drug trials and approval, and then things finally to go to manufacture, and then finally to go through insurance and everything like that, and that we have a large developing, growing evidence base of people that are successfully using these compounds, naturally grown compounds or derived compounds to treat their chronic pain and other conditions. That having legislation that's flexible and acknowledges both pathways, where we have immediate suffering right now and solutions that are getting, I think, pretty well documented, and procedures getting put in place for harm reduction and benefit maximization. Being able to offer those immediately, I think is a key focus while pursuing innovation in the pharmacological areas. Anyways, I think we are there. I would like to do this for about 3 more hours, but I know everyone's got bedtimes and things to do and other things to write. Just a pleasure to do this with you. I've enjoyed conversing with you over the years, seeing the work that's coming out of the Fathom project. I think it's going to be enormous once people understand. As I've mentioned to you, working on a current case study with Robin Carhart Harris on someone that had TBI and spinal cord injury, used a slew of a cocktail of standard psychedelics prior to their injury, and had one of the fastest turnarounds in the recovery Craig Hospital had ever seen. We just had people coming through our recent retreat, one with spinal cord injury, tethered spinal cord injury from military jet accident. They are now in significant pain relief. Their reflexive stability is increased, their loss of kinesiophobia. Someone else with TBI and endometriosis, also very, very significant pain relief. Both of them have reduced medication usage. Both of them have reduced medication usage. So when people are kind of going, is this psychological? Is this physiological? It's like, why does it have to be either or? These aren't single factor drugs. They're
Yes.
not single factor drugs.
Yes.
And it's working on the neurology, it's working on the psychology, right? And it's working systemically and it's working locally. And when you combine it adjunctively, it's almost limitless. I don't want to, but it's just every month something new comes out, and I think we've been calling this out loudly and for a long time ahead of time. Like the diabetes thing is like, we saw that in case studies earlier. Yeah, and it's great to see the larger study trials coming out validating that in the mouse models. But there's enough anecdotal reports out there that I think with good cautionary research, people will realize that there's a lot that's going on where relief is being provided, and it's being done in a responsible way. Anyways, thank you, and again, thank you to Sierra Psychedelic Society. I hope I got that right, and and the Nevada Coalition for Psychedelic Medicine. Profound work making this accessible for folks, and can't thank you all enough, and would love to do it again. So,
Thank you both. Thank you to all of you for joining. we'll try to make a recording of this available in the near term, but please follow along. Thank you, everybody.
Thank you.
Good night, everyone.